Get started then. Hi there, this is Hamza Alize. I'm an MSK radiologist at Scottish Rite for Children in Dallas, Texas. Scottish Rite, if you aren't familiar, opened in 1921 to take care of kids with polio at that time and has since expanded to take care of pediatric orthopedic conditions for all patients. And so today I have the honor of introducing my colleague, Dr. Henry Ellis. He's a pediatric orthopedic surgeon here at Scottish Rite, as well as the Associate Director of Research. He's also an Associate Professor at UT Southwestern. Dr. Ellis received his medical degree from UT Health Science Center in San Antonio. He did his pediatric orthopedics residency at UT Southwestern, followed by a pediatric orthopedics fellowship at University of Toronto. He also did a sports medicine fellowship at the Stedman Clinic in Colorado. Dr. Ellis works with a lot of the local sports teams here, including the Dallas Stars and with the Dallas Mavericks Hoops program. He's previously worked with the U.S. Ski and Snowboard Association. He's in particular very active with the Hip Center for Excellence at Scottish Rite, and he's going to be sharing some of his expertise with us regarding pediatric hip impingement. With that, I'm going to hand it over to Dr. Ellis, and I'm looking very much forward to his talk. Dr. Ellis.
Hey, great. Well, thank you for the introduction, and I appreciate you guys inviting me to talk about something that's really near and dear to my heart, which is hip preservation, hip impingement, particularly in the youth athlete. We're seeing it far too often these days. So again, really look forward to y'all's questions. Trying to give a little bit of my perspective on hip impingement, what I see when I look at the x-rays. We're going to kind of go over a case throughout the presentation. So anyways, I look forward to it and look forward to hearing your all's comments and feedback afterwards. These are my disclosures, none of which are really pertinent to this talk or really have any relevance to this talk, other than I'm a member of Anchor, which is a hip preservation group, and we're currently funded by the DoD. We're just a participant. We're not a primary site for that. Since I got involved with hip arthroscopy, really back in 2010, I always wondered if this was just a fad. Is this going to go away? Is it just really popular right now? Are we really talking about impingement and labor pathologies? Is it the lateral release of the knee or the slap tear of the shoulder? And it turns out that it is a fad, but I think it's here probably to stay for a couple reasons. And you can really look at the popularity of both hip arthroscopy and femoroacetabular impingement. You can really see quite an increase around 2009, 2010. And I think we're going to continue to learn more and more from hip arthroscopy, very, very high level evidence as well. And we'll go over a little bit of that during the talk. This is one of my favorite x-rays to really look at. I hope you guys enjoy it as much as I do. But this is an AP pelvis of Ripon. He's a 17-year-old basketball player. He comes from my hometown, came in to see me, and he started having right worse than left hip pain. And so when I take a look at this x-ray, there's a lot here to find, and there's a lot of etiologies perhaps to his hip pain. The first thing that I notice is some little bit of irregularity over the ASIS and extending down to the AIS, which probably a prior injury, a prior avulsion that is subsequently healed. I think as we further look a little bit more and dissect it a little bit more, you can see the ischial spine. Now, this is a supine x-ray, but the reality is it's a pretty good AP, pretty symmetric. We really shouldn't see that ischial spine. Now, sometimes we'll refer to that as the ischial spine sign, which may be indicative of a retroverted acetabulum, which may be a cause of hip impingement. If you look a little bit closely, you can see that he's got a crossover sign, another radiographic cue to indicate retroverted acetabulum, which may be indicative of pincer impingement. And then you can see his kind of femoral head neck offset. Really, it looks a little bit enlarged, almost looks like an osteophyte, how it has a very dramatic step to it. Probably the most impressive of everything I see on this x-ray is I feel like at a very early age, he's starting to have some evidence of some joint space narrowing. I measured that about 2.2, 2.3 millimeters when I looked at it. So very concerning x-ray, lots going on here. And we'll talk a little bit more about that as well. My preferred imaging when I'm looking for hip impingement is the 45-degree done view. There's been a lot of described lateral views of the hip. The most predictive of visualizing the increase in the femoral head neck offset is either the 45-degree done view or the cross table lateral. Now, it's all based on where this offset is on the clock face, if you think about the femoral head as a clock face. But because we actually looked at this at Scottish Rite, we determined that the cross table lateral had so much more radiation that we've really adopted the 45-degree done view. And here in Ripon, you can see here, when you look at that offset and we calculate a couple different ways to do it, most commonly we look at that alpha angle, which when you, as many of you guys know, is when you put a circle on the femoral head, you draw a line that is parallel in the center of the femoral neck, and then you draw another line that goes to where the femoral neck loses its sphericity, and you calculate that angle, call it the alpha angle, and his alpha angle was 6.8 degrees, so clearly a sign of Cam impingement. This is a drawing that I worked with some of our artists at Scottish Rite. You can see on the left side there's a normal hip, you got a normal epiphysis, you got your physis, femoral neck, and really what we see is this area of just enlargement that's around kind of that femoral head neck junction. We call it femoral head neck offset, or an increase in the femoral head neck offset, and that's really the basis for Cam impingement. Now, I'm going to say that we talk a little bit about impingement as Cam and pincer impingement. Cam impingement being from the femoral head neck junction, pincer impingement being from the acetabulum. The reality is we're still learning about pincer impingement. I'm not going to really talk too much about it in this case because I really feel like the heart of everything we're learning about the hip is really that increase in that offset at the femoral head neck junction. It's not to say that pincer impingement is not important or overall acetabular position and coverage is not important. It's just we really are still learning so much more about it right now. So you're not going to hear me talk too much about it. I like this video, and if you guys haven't seen it, it's a really good video to understand how impingement works. I show it to my patients. When I was learning it, it really helped me understand the mechanics behind impingement, because hip impingement's a dynamic process. So as you can see, when you have too much bone at that femoral head neck junction, as you flex your hip up and internally rotate, it really abuts the labrum and the edge of the chondral surface. Now, your body can probably withstand that about 50,000, 100,000 times, but then it starts to break down. And that's when we start seeing that labral tears. And many times that's how we see the labral tears appear on MRI, where they start having some fluid at that chondrolabral junction. And that's what's really indicative of a Cam impingement. Sometimes the appearance of the labrum on the MRI will tell me how this hip is impinging, because if you have that separation of that chondrolabral junction, it's almost always a Cam impingement. If you have a flattened or blunted labrum, oftentimes that's a little bit more consistent with pincer impingement. So the history of hip arthroscopy and femoral acetabular impingement really started almost 90 years ago at the first hip arthroscopy, and a lot has happened since then. You had a lot of people around that same time. Weiberg described abnormal hip morphology leads to osteoarthritis. Murray in '65 talked about how the deformity of the proximal femur can lead to osteoarthritis, and then the pistol grip deformity, which we commonly talk about. But, hip impingement and the Cam lesion really wasn't popularized until Professor Gons wrote his landmark article discussing FAI and its risk to osteoarthritis back in 2003. So you can see, although we've hinted towards this problem, it really wasn't until Professor Gons popularized it to where we really started to develop treatment for it and studying it a little bit more aggressively. Now, this is a little bit of the basis of my talk. And I'm hoping to present you guys enough evidence to have you guys believe in this as well. But the reality is, as athletes, they have a higher incidence of hip arthritis. The Cam deformity or the Cam lesion and hip impingement are risk factors for early arthritis. So the development of the Cam lesion occurs in adolescent athletes. So you can see this is a vicious cycle and probably perhaps an etiology to a bigger problem, which is really osteoarthritis of the hip. And so all of it goes back to this Cam lesion, and all of it goes back to hip impingement and what to do about it. So today we're going to talk about we're just going to review kind of the evolution of this femoral head neck offset, this CAM lesion. Where did it come from? When does it happen? What do we know about it right now? Talk a little bit about the natural history of the CAM lesion and hip impingement. What does that mean clinically speaking when you either see it on your x-rays or you know someone that may have it? Maybe some treatment philosophies, why we do what we do, why I want to address the labrum and why I want to address the labrum as well as the femoral head neck offset. Some current evidence in the treatment of hip impingement, and then perhaps some future directions in our research and how we're going to learn a little bit more about that. So we're going to talk right now about the development of CAM impingement and where it came from. Many of you guys are very familiar with the growth curve. On the left there, you'll see that's a traditional growth curve that many pediatricians use. This is a little bit more of a growth curve that I like to look at because it highlights a really important period, which is that growth spurt that you see right here. So when they start hitting puberty and their body goes through a lot of changes, you see it morphologically on the pelvis, as well as the overall shapes of the knee. Now, I'm going to propose and provide you guys with some evidence that this is when the CAM lesion develops. And it's an important concept because we don't see hip impingement or CAM deformity before they really start puberty. This really all goes back to Wolfe's Law. And if you guys haven't heard of Wolfe's Law, it's a really famous, it's kind of a really famous famous law that we use in orthopedics. Now, Julius Wolfe was a founder and the director of the Department of Orthopedics in Berlin. He really describes that if load on a bone increases, then the bone will remodel over time to become stronger to resist that force of the load. Okay, so an analogy is tennis players oftentimes have higher bone density in their forearms. You guys all know that. That's why, you know, obesity and osteoporosis oftentimes don't go hand in hand. Well, this same concept also works in the growth plate. And so when you look at this chart that was really described by veterinarian Frost, but so we're going to talk about responses of the growth plate to stress. So you're going to look at the rate of growth on the y-axis, and you're going to look at the load on the x-axis. Right in the center there is zero load. All right, and here's our graph. And what you can see is with zero load, you'll grow a little bit. With tension, the response to your growth plate will be, well, a little bit until there's too much tension. But with compression, you have a pretty significant increase in the response to stress of the growth plate until there's too much compression. And a part of this is a little bit logical, but a part of it is the thought that when you put too much load or compression on a growth plate, oftentimes it will start growing and maybe even in an aberrant way. And in this case, that leads to hip impingement and arthritis. Well, Siebenrock, just after Gons, Siebenrock wrote another landmark article, and this really highlights what happens in a majority of impingement cases. You can see our drawing was very careful. We wanted to draw that physeal scar and that extension of the physis down to that femoral neck. So what they did here is a cross-sectional comparative analysis between those with CAM and those without CAM. And what they found is those with CAM lesions on MRI, as you guys can see here on the right, had an extension of the physis down to the femoral neck, okay? And so it really may be a developmental or a growth-related issue. Siebenrock did another study a couple years later, and he took 72 basketball players and then 76 asymptomatic controls, okay? It's a case control comparative analysis, age range 9 to 25. He looked at the MRI radial sequencing, and 15% of the athletes had hip pain. The athletes had 18 degrees of internal rotation compared to the non-athletes that had 30 degrees of internal rotation. The alpha angle was 60 degrees in the athletes on average, and in the controls was 47.4. You can clearly tell here the athletes on the left and the non-athletes on the right, a clear difference and a tenfold increase in the CAM deformity. Looking at this diagram here, you can see the clock face on this x-axis of the proximal femur is really where the money is. This is really where there's a large distinction between the proximal femoral anatomy in an athlete and a non-athlete. And what you can see here is a basketball player between 12 and 3 o'clock has higher alpha angles compared to the controls or the non-athletes in the blue. You know, another study looked at not only looked at controls or no sports, but those that perhaps were recreational sports and those perhaps that were athletes. And so they looked at age over time. Younger kids don't have a lot of distinction. The older you get, the higher your alpha angle progresses. And so when you look at this here, the athlete that plays more has a higher alpha angle than even the recreational athlete. And so using these two studies in combination, I think we can conclude, you know, pretty aggressively that in the adolescent period and during growth plate maturation, more play equals more CAM. Agricola did actually a longitudinal cohort study looking at the same thing, images 2 years apart. Okay, these are pre-professional soccer players. You can see this image on the left, fairly normal looking proximal femur. Physis is wide open. Epiphysis appears pretty normal. You look at this same image 2 years later, and you can tell that the development of the cam lesion and the extension of the physis down to the femoral neck is quite impressive. So the prevalence of, in this cohort, 63 pre-professional soccer players went from about 13% with an increase or flattening of the femoral neck to 50% in boys that were 12 to 13 years old. Mark Philippon, who's really my mentor, he looked at this over Pee-wee hockey players over time. He noticed that every year the alpha angle seemed to increase, as did the incidence of labral tears. When the Pee-wee hockey players start at 12, then they did 13, then they did 14. My colleague Jeff Neppel in St. Louis, he did a systematic review and found that athletes, high-level males, were 2 to 8 times more likely to develop CAM lesions than those that were non-athletes. And you can look at the comparison between athletes and normal controls according to this meta-analysis, and you can see that alpha angles were significantly higher, as well as the prevalence of a CAM lesion in athletes versus non-athletes. I think we're all trying to figure out, where does this come from? Is it all one etiology? Is it not? I think this is one of the best MRIs that I've had a chance to look at, in which you can really see this area of soft tissue hypertrophy that really occurs at the lateral margin of the proximal femoral physis, that in time develops an osseous formation that we now call the CAM lesion. I'd say, clinically speaking, dealing with adolescents, I started noticing and have been working with Dr. Alizai to look a little bit more closely at some younger athletes that may have some clinical signs of impingement and even perhaps labral pathology. Yet I'd say their x-rays look pretty, fairly benign and not overly impressive. And this is a classic example here, in which I'd say the x-ray looked pretty normal, but you can clearly demonstrate some evidence of some soft tissue hypertrophy, or what I'm now referring to as a soft CAM lesion that may not be osseous, but perhaps it's soft tissue instead. The overall incidence, we looked at about 330 patients in our clinic that underwent hip preservation surgery. We found that 9.3% had some form of a soft CAM, some kind of soft tissue hypertrophy that occurred, and they presented almost exactly the same way that a hip impingement patient does. We compared their x-rays to their MRI, found that their MRI, when you actually include the soft tissue portion of the CAM lesion, demonstrated an alpha angle that was about 12 degrees greater between what you can see on x-ray. So it really highlights in these adolescents the importance to maybe scrutinize and look a little bit more closely at some soft tissue around that femoral head neck junction, and not just the osseous anatomy. In this same study, we can tell you most of what we think is just a thickened perichondral ring. We're still learning more and more about this. The more we see, the better we feel like we're getting at it. Hoping intraoperatively to take some biopsies of these soft CAM lesions and to start know a little bit more about it. It's just more been a clinical observation that we now have a manuscript that has been submitted as well. So hopefully we'll continue to learn more. So I think that's a pretty good early review on the development process that occurs in adolescence. And the development of the CAM lesion to me is clearly to respond to activities. It definitely occurs in the athletes. It's primarily in males, and it really occurs during peak growth velocity or really just a growth spurt. So who cares? Well, why do we care? What's the natural history of this lesion? Let's talk a little bit more about that. Now, I talked earlier about Murray, and Murray in this article back in 1971 said excessive athletic activity in adolescence is likely to be an important cause, certainly in males, of subsequent degenerative hip disease. Now, this is effectively a case series, as a lot of the early literature was, but clearly a very terrific observation that we now know much more about. Here's Gonz's original article. It's a great article and a great read if you guys haven't seen it before. But I'm really interested in levels of evidence. You know, how high of a level of evidence is this? You know, level 5 is expert opinion. I still see a lot of value in expert opinion, but level 1 evidence really is the one that's going to move mountains for us. So I'm going to classify Gonz's original article as level 5 evidence, but we're learning more and more. We'll talk more about that later. Lots of level 2, 3, and 4 evidence on hip impingement and the long-term implications of a CAM lesion. But this is where it gets really interesting. These are level 1 because they're large series. And this level 1 clinical observation series really demonstrates that hips with an alpha angle greater than 60 degrees, and again, this is 800 people, 1,700 hips, 2.42 incidence of an odds ratio for developing osteoarthritis. A little bit more of one of my favorite studies, a longitudinal analysis performed at the UK with women, 1,000 women, age range 44 to 67, AP pelvis at 2, 8, and 20 years. What you can tell here is I highlighted here the alpha angle looking at radiographic evidence of osteoarthritis at that 20-year mark. You can see alpha angle were those that had evidence of osteoarthritis at 20 years. Of needing a total hip arthroplasty, you can see here alpha angle much higher. The higher the alpha angle, the worse the hip disease progression is. In the same study, you can look, here's a diagram looking at the probability of radiographic osteoarthritis using the alpha angle as your gauge. You can see here that the higher the alpha angle, the more likely you're gonna have arthritis, and the more likely you're gonna have a probability of having a total hip replacement. Now, doing that same concept, but looking at adolescents. So this is a prospective matched cohort study looking at adolescents, 12 to 18 years old. Found that those that had alpha angles greater than 55 degrees with limited internal rotation was a predictor of an increase in tonus grade. It may not be severe osteoarthritis, but it's a sign of early joint space narrowing. So I think these are clear, high levels of evidence to demonstrate that the CAM lesion is bad. So the natural history of a CAM lesion, it's a clear risk factor for developing idiopathic arthritis. Higher the alpha angle, the higher the probability you're gonna have osteoarthritis. All right, so what's our treatment philosophy now, and what are we trying to do for it right now from an orthopedic surgeon or a hip preservation surgeon? So just to recap a little bit, hip impingement, it's bad. These alpha angles are bad. It develops in our youth. It leads to arthritis. We do know that it can improve symptoms in the short term with therapy and surgery. There is some good level of evidence with it, but we don't know if we can change the natural history. Here's some evidence on different treatments for femoroacetabular impingement, particularly in the adolescents. A friend of mine, Andy Pennick, in 2018, AGA-SIM found 82% improvement with physical therapy, but no real long-term implications with that, or I heard that it's actually being published soon. Loads of case series about arthroscopic treatment, including my mentor, Philippon. I helped him with that article in 2012, revision arthroscopy. So it works. It works, at least in the short term. And so my treatment philosophy, whenever I am approached with a patient with this condition, is I need to address the labral and chondral disease, and then I must remove the osseous overgrowth. I think it's really clear that we need to address both of those in order to treat their symptoms and try to create some longevity to the hip. Now, I'm going to show you guys some arthroscopic images, but I just want to orient you guys a little bit. And I apologize if this is remedial, but this here, on the left is the MRI. We got the femoral head, chondral surface, and the labrum. Over here on the right, the femoral head is usually the spherical structure that you always see. It's usually in the bottom corner, just from the angle of the camera. The labrum is the rubbery rim that's around that acetabulum, and then you have the chondral surface, the acetabulum. Above the labrum, typically you'll see a capsule. Frequently, it can be hyperemic. Frequently, we'll see some synovitis with it as well. Here's back to Ripon. This is Ripon's MRI. You can see he's got a pretty nasty tear with a clear detachment, but also some intersubstance signal within the labrum too. So he's clearly got a lot of labral disease. I've really gone away from using arthrograms. I believe that the 3T MRI has really helped my understanding of chondrolabral pathology within the hip. But I would say we really don't always know exactly what we're doing with the MRI and having good ideas of what the MRI is showing us. Now, Andy Panic and a few of my colleagues from Vail did a study looking at asymptomatic participants, prospective blinded study. Charlie Ho, who's a good friend of mine, was a radiologist involved, didn't know the clinical picture behind these MRIs. Healthy active adults, 72% abnormalities on MRI, 69% labral tears. So many times I wondered to myself, is this really the herniated disc, in which sometimes we are calling labral pathology labral tears when oftentimes it's just normal variant. I still don't know how to distinguish between the two and find it frequently the correlates between what I find arthroscopically to the MRI. And that's really what we enjoy doing at Scottish Rite when I get to sit down with the radiologist and we get to go over some images together. Here's just an image of a really severely diseased labrum. This labrum really has a lot of hyperemia to it. It's bruised, a lot of chronicity. It's unstable. The chondral labral junction is unstable, although it's not frankly torn and I can't pull it away. Really a lot of concerns about this labrum. When I looked at that MRI, as did the radiologist, we really found very little labral disease, or what I thought was very little labral disease. But the labrum is really important, and it's important in our treatment consideration. We refer to it as it creates the suction seal. So if you guys don't know what the suction seal is, the suction seal is the ability of the labrum to cause a seal around the hip to give it stability so that it can hold within the socket relatively well. A lot of our prosthesis work in the leg that way. Jeff Neppel gave me this video. This is with an intact labrum. You can see how much pressure they're pulling on the head in order to pull it out of the cadaveric specimen. This is with it torn here. And so then when you reconstruct the labrum, you can see that you regain that suction seal that holds that femoral head in the socket. Now, it's more than just stability, because the fluid within the hip really it minimizes the friction, but it also distributes the force transmitted through the hip. And so when you have a labrum that creates a suction seal and the yellow of the fluid, it really allows, when compression to occur at the hip joint, it really distributes the stress and the force throughout the hip joint. And so it really protects the cartilage and protects cartilage deformation when you retain that suction seal. So you can see now how the cam lesion and the labrum together are really very important. This is an MRI. This is an MRI study on cadaveric sequences. They use a fat-suppressed 3D flash sequence to evaluate the articular cartilage with and without resection of the labrum. The top image is with the labrum torn, the bottom is with it resected. Jeff Neppel looking at the importance of the suction seal in a cadaveric specimen. They looked at the force in newtons of distraction of the capsule and labrum intact. You can see when the capsule was removed, it decreased the force a little bit, but when you took out the labrum, it had almost nothing. So alpha angle and labral disease, they really go hand in hand, and they're really important. And so we did this study recently in which we looked at 109 hips, and we were trying to figure out how bad the chondrolabral pathology was with the alpha angle. You can see here, We used 86 of 109. These are the patients we've seen at Scottish Rite. Most of them were involved in athletes, and we had about a 3-year follow-up. What you can see here in these tables is the higher the alpha angle, the greater the labral disease and the greater the length of tear. So there seems to be a direct correlate between how large your alpha angle in your cam lesion is and your labral pathology. It goes straight back to the conversation we had earlier, trying to demonstrate the importance of the cam lesion in relationship to the development of osteoarthritis. So the chondrolabral disease is just right in that sequence. So I talked about the importance of addressing both the labral and chondral disease when we treat this, but you also have to get adequate bony resection. I use fluoroscopy when I do this. We do it arthroscopically now. You can see this is a pre and post-op images using the 45-degree gun view, demonstrating the adequate resection to try to demonstrate or recreate the sphericity around the femoral head. Now, it's really not just Paul Bolle did this article really looking at the value of the T1 row images 2 years after doing an osteochondroplasty, and really demonstrating that it really significantly decreased the values that were provided using this MRI sequence. Also demonstrated this one that the bone mineral density also decreased as well. So couple great information about just the concept of doing the osteochondroplasty and how it does have chondroprotective properties according to T1 row. So in conclusion, this is when I'm done with the surgery, looking at the labrum, the hips back into the socket. I'm looking at the labral repair right in here, recreating that suction seal. And you can see I can dynamically move the hip around, and you can look and see if we've resected enough of that osteochondral offset. So what's our current evidence about the treatment of hip impingement? Now, I mentioned before, I'm a part of the academic network of hip surgeons. We call it ANCHOR for short. We're just one of many, many institutions that participates in it, but there are a lot of study groups looking at the hip right now, and I'm amazed by how much high-level evidence there is in our treatments right now. Going back to this kind of diagram of levels of evidence, I'm going to tell you that the randomized controlled trial, really high-level evidence, we're seeing quite a bit of it in hip impingement. I'm going to talk to you a little bit about I'm going to highlight a few of my favorite studies. This is an American study. It's a military study, and it really looked at 40. These are all patients, active military, that were randomized who had hip impingement. You had 40 that did physical therapy, 40 that did hip arthroscopy. Okay. Now, their conclusions were that there was no significant difference in their outcome, but you got to read really carefully because they had 70% crossover from the non-operative group to the operative group. So the reality is 25 patients didn't tolerate the physical therapy group and ended up having surgery anyways. So it's a pretty important consideration. Even though they may conclude that there was no difference, a lot of them ended up needing surgery anyways. There's another great study out of the UK looking at 12-month outcomes, really found improvements in both groups, but found when they adjusted for impingement type, sex, baseline scores, hip arthroscopy cohort had a greater improvement. And so it goes back to the concept, probably the worse the disease, the more likely improvement that you're going to have. I really like these additional studies that are coming out of the UK as well as Australia that are doing short-term outcomes, but they're also looking at some of the MRI work. So this study out of Britain had early outcome, but what's more important is they're going to report 3-year outcomes using the T2 mapping, serum markers, and really economic data. And then we have several randomized controlled trials looking at hip arthroscopy with an osteochondroplasty versus a sham surgery. And this one just got published last month in AJSM, looking at osteochondroplasty labral diseases. This is out of Canada. And what they did is the surgeons, you were randomized as a patient to either undergo an osteochondroplasty with a rim trimming around the acetabulum. If you needed a labral repair, they gave it to you, or a sham surgery, where if you needed a labral surgery, they did the labral surgery. At 12 months, no difference in pain or outcomes. However, those that did not undergo an osteochondroplasty ended up having much higher rates of reoperations. And this is really early outcomes. I think we're going to find that repairing the labrum and not taking care of the bony pathology is just going to cause for a high rate of reoperation and perhaps some suggestion of the future need for developing osteoarthritis or a total hip. So I think, being an orthopedic surgeon, I look for high levels of evidence, and being a hip preservation surgeon, I can say that I really believe that we started with level 5 evidence, but today in 2021, we are really seeing high levels of evidence that we're doing the right thing. Patients are getting better. And I think we're only going to find that addressing both the chondrolabral problems is the short-term fix, but really the bony pathology is really the problem. Now, I'm a pediatric surgeon, so I'm constantly wondering what is our future perspective. And I'm going to tell you right now, we're going to continue to treat it as it arrives to our clinic. But the reality is we need to continue to have a focus on injury prevention. We really need to consider healthy ways to help frame our message to youth athletes and to coaches. Now, parents are what drive coaches and clubs, and really at the height of their growth spurt is when most of these bony changes that have long-term detrimental effect are occurring. And so we really need to be very knowledgeable, and we're not going to do it. We got to convince the parents to do it. But the important is high-level athletics during peak height velocity may cause long-term detrimental effects to the hip. So we really have to be grounded. I continue to preach sports specialization, variety in sports, and really during periods of height and growth, you really just need to dial it back for a couple of years. I think the parents feel like you can't do it, but the reality is if you can do it, I think you're going to have more longevity with your athlete. So this is just my treatment philosophy. I educate them. I try to teach them. I do not tell them who needs what, but I tell them this is the deal. Here's the data. I do think an accurate diagnosis is important. This isn't a hip flexor strain or adolescent dysplasia. I use injections to help me figure that out. Large cam lesions are ones in which I generally tell them I'm concerned about risk of developing degenerative changes, and I have to watch you closely. That means I'm going to see them in my clinic every 6 months, even if they don't have pain. I do like hip injections. I do think they work very, very well. I will not consider any kind of surgical treatment without a minimum of 90 days of physical therapy, because I do believe there is a lot of spinopelvic immobility that causes dynamic impingement. And so there are ways in which we can move the pelvis and shift it around, much like we do the scapula, to help improve some of the impingement. So I don't consider prophylactic surgery right now, and I do consider bilateral problems. If you have surgery on one, you do it prophylactically on the other. I don't know the answer. I haven't really been an advocate of that just yet, but I'm becoming more and more convinced. So before we go to questions, I'm just going to tell you what happened to Ripon. Well, Ripon becomes even more interesting, and I'm sure many of you guys already saw this, but when you take a closer look at his x-ray, you can see here that the actual weight-bearing dome is a little bit more blunted. It's not quite as big as you think it is, because he's got a little bit of this flare or this edge that really is a little suggestive of hip instability. When you calculate his center edge angle to the lateral aspect of the source seal, his center edge angle is 17.2, which indicates borderline dysplasia in a young athlete. We took a look at a false profile and really can demonstrate that he's got quite a bit of loss of anterior coverage. So he's someone that probably has combined pathology. He's got a shallow socket, lateral center edge angle less than 25 degrees, anterior center edge angle is less than 20. We calculate it just at 10 degrees. His tonus angle is greater than 10 degrees. So I do use a CT scan now. I think it's very helpful to look at acetabular morphology in 3D recon images. But this is a great image because he's got so much going on with his hip. It really allows or affords for us to learn quite a bit. So we went ahead and performed an osteochondroplasty. He had bad labral disease. You can see that right here. And he underwent a pelvic acetabular osteotomy. in order to give him appropriate coverage of his acetabulum as well. So he went back to play basketball his senior year. They got really close to state, so he was really excited. He has a little bit of pain in his left hip, but he really doesn't want to have to go through that big surgery again. That big pelvic surgery was pretty painful for him. So I want to say thank you guys for having me. I hope you guys enjoyed some of the information that I talked about, and hopefully it can help you guys or all of us learn a little bit more about the hip. Really need to utilize our ability with the advancements with MRI are really going to change our understanding of procedures and surgeries that we believe are chondroprotective. And we're going to continue to learn how to utilize T1 row, T2 mapping within our treatment process. I know there's been a lot of that in the last 10 years, but we're still in our infancy of really understanding that. So thanks again for having me, and would be happy to answer any questions you guys might have.
All right, we have one question in the chat. Have you seen Cam in teenagers with open femoral physes?
I have. So there's two different ways in which I've seen this. Number one, I can begin to see the physeal extension over the lateral neck early on. Sometimes you can catch it on the x-ray, but oftentimes I'm seeing it more and more on MRI. Before you see the osseous development of the cam lesion, we're starting to see a little bit of hypertrophy of the perichondral ring with extension of the physis beyond that.
All right, we have two thank yous and one question. I noticed on one of the studies that there was also increased OA with decreased alpha angle, but not an increased THA in those patients. Any thoughts?
No, I don't. I think oftentimes we have to, the alpha angle itself, time and time again seems to be directly correlated, not in our adolescents, but in these large cohorts with the progression of OA. And so, I think some of these studies, having looked at them, every study has limitations. They're large population-based studies. The one study from the UK was really, it's 1,000 AP pelvis. Well, we know we really don't always look for impingement or the cam lesion on AP pelvis. We almost always see it more on the lateral. So I think there's some limitations in these population-based studies, but I think the trends are pretty clear that the cam lesion, higher alpha angle is leading to OA. The higher it is, the more likely you have OA, and it's eventually going to lead to a hip replacement.
All right, one more question. Is there an age that you would not do surgery?
For hip impingement, so I've done hip arthroscopy on someone as young as 6 months that was primarily for a septic hip. Hip impingement, the youngest I've done it on is a 10-year-old. But the problem is it's extremely rare to have true hip impingement at a young age. Oftentimes I see it more in relation to Perthes or other developmental problems of the epiphysis. True idiopathic impingement usually does not occur until that time that you hit your growth spurt. If I see it early on, these are the kids in which I really believe we need to wait a little bit longer, allow physical therapy, allow some of their pelvic mechanics and their pelvic tilt to try to accommodate for the hip impingement. I've noticed in my practice, I've been doing this now 10 years, there's one study that demonstrates the younger you do the surgery, the more likely it's going to come back. So if you do an osteochondroplasty in the presence in which the proximal femoral physis is open, I think you have a higher chance that you're going to have a recurrence of that overgrowth phenomenon. I've seen it in my practice, and it's now been published. So if you do it when they're too young, I think the problem is it's just going to come back. And so if you can wait a little bit longer, now some kids, they can't because clinically they can't tolerate it. But the reality is you want to wait until that physeal scar starts to develop.
Is there an upper limit? The question clarified. I understand you're a peds surgeon, but asking in general terms.
Yeah. You know, the literature on hip arthroscopy with impingement would tell us that the joint space on an AP, on a standing AP pelvis, is probably the most predictive of the outcomes of a hip arthroscopy. And so a joint space that is more narrow than 2 millimeters at any measurement along the femoral head and the acetabulum of the psoas seal is a poor predictor of a good outcome with the hip arthroscopy. So insurance companies, as well as hip surgeons, would tell you if you've got less than 2 millimeters of joint space, a hip arthroscopy is not going to give you what you want. Your arthritis is already too far out.
Interesting. One more question. I'm confused about Ripon. I thought that FAI and DDH were mutually exclusive. If the acetabulum is shallow, how does a cam impinge?
Ah, that's a great question. Thank you for asking it. They are not mutually exclusive. And actually, looking at symptomatic adolescent hip dysplasia, about 60 to 70% will have evidence of a cam lesion, okay, or a increase in your femoral head neck offset. Now, if you think about the mechanics, oftentimes an acetabulum that is dysplastic or borderline dysplastic, you may have a little bit of loss of lateral coverage or a little bit of loss of anterior coverage, but your hips can still flex up and pinch the side of it. And so we're seeing combined pathology. Right now, we're in the middle of a randomized controlled trial looking at that specifically. But the reality is we do see combined pathology. They are not mutually exclusive, particularly in the adolescent. And I think it's even more important to recognize some of my early failures in my career as a hip arthroscopy surgeon were those in which they predominantly presented with hip impingement, in which they had borderline hip dysplasia, subsequently continued to have symptoms that was attributed to hip instability. And so they went back to the operating room for a pelvis acetabular osteotomy and has subsequently done very, very well. And so you have to be mindful that combined pathology can happen, and we are seeing it quite a bit.
Okay,
Great
great.
question.
Thank you. One other question regarding the MRI report, which findings would make you think about instability in labral and chondral tears?
Yep. So I think it's very hard on MRI to really distinguish hip instability. It's a dynamic motion, and I would tell you, even in the clinical setting, when I'm examining a hip, I oftentimes find it a challenge to look for instability versus impingement. However, the only MRI finding that I'm particularly sensitive to is having an enlarged labrum. We know it's a developmental process. So oftentimes if you have hip instability as a young kid, that your acetabulum would, as a compensatory mechanism, will have an overgrowth of your labrum. And so when you have that big enlarged labrum that's upwards of 15 millimeters in length, anywhere greater than 10 millimeters in length, I start getting worried about it. So it's really labral size, but not necessarily labral tear pathology.
Okay, and one more question. How do you manage associated chondral degeneration, and where at the weight-bearing surface if it is at the stage of moderate cartilage loss?
I'm sorry, was it asking about radiographically or on MRI?
I'm not sure.
Okay.
Did the person who asked the question, they can unmute themselves and clarify? At arthroscopy, he's clarifying.
Oh, during arthroscopy.
Correct.
Yeah. So oftentimes you can't tell the difference arthroscopically. You've got to just treat the cartilage problems as you see them when you're performing an arthroscopy. So that weight-bearing zone is sometimes much more challenging to see arthroscopically. Now, I'll tell you that, like anything that I do, I've got to use a combination of what the X-rays show, what the MRI shows, and then what I see arthroscopically. Sometimes on MRI, you'll see chondral thinning and you may even see focal defects either in the acetabular rim or the femoral head. But yet I still have adequate joint space narrowing on x-rays on a standing AP pelvis. So to me, I still think that they may benefit quite a bit from addressing the chondral problem in the hip, either a microfracture or any kind of cartilage regenerative or replacement procedure. But if they have 2 millimeters or less of joint space, I know that that hip's probably too far gone. Arthroscopically, it's a little bit like the difference between a radiologist and orthopedic surgeon is we all look at MRIs together, but I get to examine the patient, so I have a little bit of a benefit. It's the same thing arthroscopically. Is I have the benefit of looking at X-ray and MRI, and then I get to go in there and I get to probe the cartilage lesion and see where is it thin, where is it not, where is it soft, and then focus my attention at that time.
Great. Any other questions? I had one question. If you're advising parents about their children getting into athletics, what would your advice be?
Yeah. So, number one is I think moderation is really important. Our culture right now is suggestive that kids need to play year-round single sports. You're having your baseball players that are having to play baseball in the fall, in the winter, in the spring, in the summer, and their arms and their shoulders are being torn up. I think we're seeing that in almost every sport. We're seeing it in basketball, we're seeing it in soccer. So you've got to have some moderation. Rules of thumb that I use are you should not play any organized sport for more than 9 months per year. You should not play organized sports more hours per week than your age. I advocate everybody to play multiple sports, but especially you cannot choose a single sport till the age of 14 for those athletes. So I try to use those rules of thumbs as best I can. But I'll tell you, many of you guys are on this call. I'm a parent of, 2 sporty kids. And I mean, they just want to play sports all the time. It's hard to say no and have them take a season off. When you're in that environment, you think, well, this won't be me. But we're going to have to continue to advocate as best we can.
Great. Thank you very much.
Dr. Ellis, that was fantastic. Thank you so much.
Thank you guys. I really appreciate you guys having me, and I look forward to meeting you guys. Maybe one day we can do something similar live. I'm really looking forward to an event in which we can start seeing each other's faces and feeling a little bit more personality behind these talks. So thanks again for putting up with me on my home computer.
Thank you.
Thank you very much.
Good night.
Take care. Good night.